The passage of the Affordable Care Act of 2010 by the Obama administration was highly publicized in the media. What may not have been immediately clear from the coverage of the changes is the impact that health reform has had on the healthcare delivery system, and how these changes would change the nature of medicine as doctors know it. From reform to electronic health records to the Columbia Free Medical Clinic, this ethnography features comments from 9 Columbia physicians. This documentary includes nuanced commentary on multiple topics, including the future role of primary care physicians, how the role of nurse practitioners has changed the nature of the medical delivery system, and the physician's struggle for autonomy in an increasingly corporatized healthcare delivery system. You are watching The Future of Healthcare Delivery. The keystone of the Obama administration has been passage of the 2010 Affordable Care Act, designed to increase affordability and quality of health insurance and also reduce healthcare costs for both the government and individuals. To expand coverage, the government has made available health insurance exchanges to ease access to insurance for those who can afford insurance but never bought it, while providing subsidies for those who have not been able to afford it. Those who do not purchase insurance by March 31st of the year 2014 are subject to financial penalties on their federal income tax.
So before you start going out and finding federal funds and everything to get people for the government to pay for health care, you got to find the people that can already afford it. And so, give you an example. So, how many people that can't afford health care have cable TV that they pay $140 or $200 a month? Well, they've got cable TV, they've got HBO, they got Showtime, they got all kinds of fancy channels, they got TVs in every room that they watch that cable in. Cable boxes all over the place, blah, blah, blah. Okay? They also have a cell phone that has the ability to text, Instagram. They've got, the smartphone that's got a big old giant screen TV. They can watch videos on it and everything like that. And then their phone bill every month is $160 as well. But they get hurt or they sprain their ankle, they go to the emergency room and it's free.
Prior to health reform, 50 million Americans were uninsured. To date, 8 million have signed up for insurance on the exchanges since the healthcare.gov website opened in October 2013. Promisingly, a high proportion of those who signed up are younger Americans. Even so, about 42 million are projected to remain uninsured even with the insurance exchanges. The plight of the uninsured is felt strongly in doctors' offices.
I can't tell you how many times I have had to have somebody with chest pain who needed a stress test, yet I knew that they would be financially destitute if I ordered the stress test. And so we found ways to sort of treat this and manage it, and yet you worry, please don't let this be an unstable coronary syndrome.
Additionally, some states, including South Carolina, decided not to expand their Medicaid programs. An estimated 340,000 South Carolinians would qualify for Medicaid if the program were expanded. The government-funded Medicaid expansion money was turned down in order to pursue state-based solutions, leaving those who would have qualified reliant on other means for obtaining medical care, including visits to the ER.
We don't make any differentiation when somebody arrives at Palmetto Health in our emergency room as to whether they can pay or not. We provide that care. And that is legislated. We have to provide care. That's very different in the outpatient setting when somebody is trying to receive preventive care. We do a lot of that as well for poorly funded and unfunded patients. Our hope is that somehow the expansion of coverage for uninsured patients in South Carolina will be achieved, perhaps through the exchanges this year or next year, or perhaps through some kind of legislative agreements where they actually do expand Medicaid coverage.
Thankfully, some uninsured are able to find medical help at free medical clinics. Here in Columbia, the Columbia Free Medical Clinic provides free medical care to patients who cannot pay for health care elsewhere and who have no health insurance through Medicaid, Medicare, or private means. However, with limited resources, the free medical clinic can only go so far to help the state's neediest patients.
The benefit of the community is tremendous. I mean, we have people that need, I mean, our patients here are, a lot of our patients are sick people. These people are, a lot of my friends and people I talk to socially will say, oh, you know, you're at the free clinic, and they've got some idea that all we see are runny noses, or we're like a Planned Parenthood office. I mean, we don't do any Planned Parenthood. We are not an abortion clinic. We don't do, you know, we don't prescribe narcotics in here. We see people with chronic illnesses and acute illnesses, and we treat them and manage them. The fact is that we don't have great visibility, and it's
So
as much as we do, it's like a word of mouth clinic. Mm-hmm. You know, so yeah, it would be nice to have like
better advertising.
Yeah, I mean, you know, better locations cost money. You know, advertising costs money, signage costs money, and we're a free clinic. It's unfortunate that I have patients that are compliant, and they're doing. I mean, they are doing their best. Their heart's in it. They want to get better. They've been doing everything that they should do, and then they come in here one day and their long-acting insulin's out of stock, and they're literally crying. I mean, they're you know what. I don't understand. We just don't have your medicine. And now I've got to completely change their regimen. I've got to come up with some, I call them battlefield medicine tactics, you know, to try to shore up the deficit until we get our insulin supply back in. But, you know, it is, like I said, it's just one of these things where you have to adapt, and you just have to always have a plan B. Mm-hmm. But it hurts the patient, because you're taking someone that they're doing everything they're supposed to do.
One big part of the Affordable Care Act has been to increase the number of primary care practitioners by providing financial incentives, including 10% Medicare bonuses and National Health Service Corps scholarships to recruit medical students to primary care through medical school loan repayment. But are financial incentives enough to recruit more doctors to go into primary care in order to cover the new waves of insured people, or are other forces at play?
I think most medical schools these days have an emphasis on trying to produce primary care doctors and things like that, but you know, it's difficult to force people to do it. The question is, it sounds good, but are people going to go into primary care? You know, again, reimbursement is bad, so primary care doctors don't make very much money. You've got you're producing a population of people who have to go through 4 or 5 years of undergrad, and then they have to go through 4 years of medical school and 4 years of residency training. So you're talking about, you know, 14 years of training, and then you're going to tell them, hi, you're only going to make X amount of money, and let's get you to work into a low-income area or a place that needs a primary care doctor, and then they've already got $100,000, $200,000 in debt from the education they have to get through. So it's difficult.
These days, radiology, dermatology. So the brightest and the best are picking new specialty areas. Some of these are lifestyle favorable. But I think it's because for some reason we don't revere primary care the way it once was. For some reason, students just don't go into it. And it may be that for some reason being able to do a procedure and penetrate the body with an instrument just seems cool. It's kind of cool, but again, I'm just not sure of what the reasons are, but I don't think financial incentives are going to be enough. Another great mystery, though, is that we're trying to increase the numbers of primary care physicians. Yet, for many people, many individuals, the emergency room remains their point of medical contact no matter what. Yeah. And it's like even if we increase the number of primary care physicians, they still seek care in that setting first.
I think there are several reasons for uninsured or underinsured people. The ER, a community emergency room, can be free. In other words, you know, the hospital being funded by Medicare, Medicaid, and seeing underserved community ends up writing off a large amount of hospital expenses serving these uninsured people. For instance, I saw a lady last night who brought her child in to the hospital. She'd recently lost her insurance, and her primary physician was going to basically have her pay full uninsured price for regular visits to their office, which she can't afford at all. So she's using the ER now as her, you know, kind of sick care for her child until this gets sorted out. Another issue is, I think, just the immediacy of it. People can, if they wake up in the middle of the night feeling unwell, we're open, we're there. You know, they don't want to wait till the morning and try to get squeezed into their busy doctor's office.
It is projected that currently 17,000 primary care physicians are currently needed to fill shortage areas in the United States, and 52,000 will be needed by the year 2025. Physician extenders, such as nurse practitioners and nurse assistants, have been critical to taking care of the primary care needs of the American population.
I've worked for the last 10 years with a nurse practitioner, and it was absolutely an enjoyable experience every day. She knew her limits, I knew my limits. I knew what she was better at than what I was. And we treated each other like colleagues. I think you're going to find more of that, perhaps though with a primary care practitioner working with 4 or 5 physician extenders.
Who's going to take up the slack? I mean, I think it's what, 30 or 31 million more people are going to be thrown into the mix, okay, for needing primary care. They'll be newly insured. Where are they going to go? We're not graduating enough medical providers, DOs and MDs, to make up the deficit. The slack's going to be taken up by NPs and PAs.
Because nurse practitioners perform several services similar to primary care doctors, the lower reimbursement nurse practitioners receive for the same services is a discussable issue.
I don't think it's fair to compare a doctor that finished 3 years residency to a brand new nurse practitioner out of the gate. But you know, you add 3 or 4 more years to that NP's training, and then where are they at? They're probably in the same place. They're probably able to deliver equally effective care in a primary care outpatient setting. They're going to order the same test. Parity and reimbursement, I think right now, is the bigger issue. We should be paid the same for the same service as the MD. If a patient comes in with hypertension and I treat them and manage it, and the MD treats them, they're going to get a better reimbursement. They're going to get, what, 15 to 20% more reimbursement than if a quote-unquote mid-level provider, you know, I don't like the term mid-level because we don't do things at 50% of the speed, you know. I mean, it's like a mid-level, it's like you're halfway there, you know. Well,
right.
We do the same thing.
Exactly.
Within our scope.
Right.
You know. I feel like I should get paid for the same service.
A rise in healthcare costs over the past few years helped trigger the urgency to pass the Affordable Care Act. True to its original goal, the healthcare law is costing $5 billion less to implement than it was projected to cost in 2014, according to the Congressional Budget Office. Several cost-saving measures have been discussed to stem rises in healthcare costs. Some have advocated for reductions in physician salaries, especially those in specialties and subspecialties. But would this really be a good idea? And would it really save us that much?
Well, I think neurosurgery is an important aspect of medicine and surgery, particularly trauma surgery. But being realistic about it, neurosurgeons form only a very small percentage of the overall number of doctors. For example, I think there are probably 10, maybe 12 neurosurgeons in Columbia. What we add to the costs of medical care in the United States is probably less than 2 or 3% of the total cost of medical care in the United States, and that's even though neurosurgical procedures themselves tend to be expensive. And part of this is because so few people come to see us. Most people will live their entire lives never coming to see a neurosurgeon.
High quality, cost effective is the touted trend in healthcare. One way hospitals are reducing their healthcare costs is through choosing quality yet cost effective medical devices.
And what they're doing is that the hospitals and medical systems are deciding that, they're high, we want to have one version in the hospital, who's going to give it to me cheaper? And so that's coming into play in terms of different devices, knee replacements, different implants. Surgeons always have a choice, but I think that the choices are getting tighter and tighter because, again, financially the hospitals have to survive. And so, before, I think a lot of medical supply companies and medical device companies could kind of charge whatever they wanted to charge, and physicians were consultants and physicians were picking whatever they want. Now I realize that I can't always use something just because I like the company. If the device is cheaper and I think it's an equivalent, then for the most part I try to do that because I know that it makes a difference for the hospital. So I think the choices are going down.
Cost pressures, among other factors, have caused medical practices to consolidate into larger groups or become completely absorbed into hospital systems. Although consolidation allows the business aspect of medicine to be run by more business-oriented people, physician autonomy may be sacrificed to some degree in the process.
It's become a trend, a big, important trend, that doctors are sort of leaving small 3 or 4 man groups and joining with larger groups, maybe under the auspices of a hospital, maybe under the auspices of a university such as the School of Medicine at USC. Sometimes they will coalesce into one large medical group and maybe even a multi-specialty group. And the reason they do that is because it's becoming more and more difficult to bargain with or negotiate with insurance companies for reimbursement. And if there are, say, 2 or 3 or 4 small neurosurgical groups in a community, then it's much easier for an insurance company to go to one and say, we'll pay you X amount for doing a lumbar disc. And if they accept it, if that group accepts that fee, then all the other groups essentially have to accept it. Otherwise, they won't get any patients. The insurance companies will just deal with the group that's willing to accept the lowest fee. So you can see how large insurance companies, being big business organizations whose job is to keep their costs down, you can see how they can easily bargain with numerous small groups of independent practitioners. Whereas if they are dealing with one very large multi-specialty group that includes all of the doctors in various specialties in a community, then the insurance company has sort of lost their bargaining power, and the doctors have taken that bargaining power unto themselves because they can decline to see those patients.
Would you feel like your autonomy is being taken away?
I think so. Yeah, I mean, working for a hospital, you're technically, you do have a boss, the hospital administrators, and they're, of course, they're more interested in the business aspects of medicine, and that doesn't always, from a physician perspective, mesh with what you're doing on the ground. Like, is it helping patients and helping you provide better care? So I think there is more opportunity in a hospital employed setting to kind of butt heads with people.
One highly sensitive and controversial issue that intersects medical ethics and resource allocation concerns end-of-life care. For doctors, the conflict arises when using all the latest technology and drugs may yield only a very small or short-term benefit for the patient. At what point should a doctor decide that more medical care is futile? Who should be making such decisions, if not the doctor?
There was a study that came out within the past couple of years about lung cancer and end of life. It was a fairly big study.
Yeah.
And about half of the patients were treated with chemo until the very end, and the other half were treated, but they emphasized palliative care and hospice care toward the end. And it looked like the patients that there was less emphasis on futile chemotherapy, more emphasis on quality of life. They actually lived a little longer. And it got a lot of people's attention. I think that a lot of oncologists, once they get in that patient's room, they want to treat the patient. They want to do everything they can to fight the cancer. They don't want to let the hospice people take over, the palliative care people take over, especially earlier in the patient's course.
Right.
You walk in there, the patient looks good,
Right.
but you know they're dying from their cancer. You still want to try something, but at some point you need to decide when to stop, or at least give the patient a break from treating them with all of this, quote, harsh therapy. I think we've probably, it's a point of diminishing returns. We spent so much time and money on certain treatments that we missed the point. That
Yeah.
we're all going to come to a point where there's nothing else to do. And we haven't really focused on that time once you stop treatment. I think if we emphasize on how to keep people comfortable during that time when you do stop treatment, I think that's going to be a major change in healthcare. Making your last days comfortable and pain-free.
Useless preventive care, spending $100,000 in the last 1 month of somebody's life who we know is destined to die, suffering in the ICU, but because somebody insists on it, and so things all over the place. Spending hundreds of thousands of dollars on the newest cancer drugs that the randomized trials show extend life by 1 month on average.
I wanted to know whether physicians thought the supposed cost-saving and quality-enhancing measures of the Affordable Care Act would be effective over the long term, and if not, what they think the ideal healthcare system should be. Here is what I got.
No, it's not going to be successful in my view, for a variety of reasons. One is that the way people still practice makes people still somewhat unaccountable for what they generate. And as long as, elements of fee-for-service are preserved, without controlling it in some way, I think, and as long as people sort of get reimbursed for things that may not necessarily be effective, which this, all these tinkerings that you talked about, it's still early on. Nothing has really happened yet, right? It's hard for me to imagine, from what I understand about it, so forth, that the Affordable Care Act is going to fundamentally change the way people practice medicine in this country. Now, having looked at what's happened in this country over the past 30 years or whatever of my career, by far to me, I think the model that we should have adopted and that hopefully we'll adopt someday is a single payer healthcare system. And there's a couple of ways that's done. And you know, there's some room for flexibility there. So one is the Canadian model, where the private insurance industry is out the window, removes huge overhead costs, because a lot of the excess costs that we didn't talk about before are just pushing paper and the infrastructure and the administrative staff of thousands of insurance companies in the United States. Gets rid of that. And it's a single payer, like Medicare is a single payer in this country for people over 65. So basically, that's like giving everybody a Medicare card when you're born, as opposed to when you reach 65. And in my view, there's really good data to suggest that if that was the model here, but we covered everything more or less the same that decent insurance companies do now, that there would be a huge cost savings, because this sort of like 10 or 15 cents on the dollar that we spend for administration in the United States would be out the window. And that's one of the things that drives doctors nuts, you know, in doctor satisfaction surveys, trying to sort of juggle all these different expectations from different insurers. Then it could go two ways. Doctors could still get reimbursed fee-for-service under a single payer system, which they are in Canada. So they're not salaried. They still have private practices and are fee-for-service. It's just that there's only one insurer. Okay?
Oh, okay.
At the other extreme,
okay.
if you go to the United Kingdom or England, where most doctors get paycheck salaries from the National Health Service. So there's different models, way to go, and you know, it could go in multiple directions. But I think the biggest change that would make a difference, and I even know some sort of conservative-leaning physicians now who say, you know, single payer may be the way to go, because our lives are being driven nuts by, you know, the chaos of the current system.
The implementation of electronic medical records was accelerated by the Affordable Care Act because financial incentives were provided for hospitals and practices to move towards electronic systems. Plenty of physicians were already ahead of the curve in implementing these electronic records. Here are the positive ways physicians say electronic health records have influenced the nature of their practice.
I can instantly access the patient's chart. It comes up on a separate screen automatically. So when I launch a case, the case comes up on 3 of the screens, and on the 4th screen, the patient's medical record comes up, and I can get access to their medications, to their surgical history, to what their chief complaint, what their symptoms are, all that. Consultations. If they're in the hospital, I can get copies of their op notes. I can look at their path reports, their labs. It's beautiful.
Even electronic medical records are helpful. You know, I can be at home and have a patient question pop up, and I can pull up their chart from home. So that's helpful. You know, 3 or 4 years ago, I didn't have that ability to do that. You know, I can get X-rays and MRIs and all that stuff online now. So you know, again, access to the medical record and for patient information is actually critical to being able to do as much as we do.
We can actually see what medications have been filled by the pharmacies. You know, that's a cool thing too, because we know from the literature that about half of the prescriptions that you hand to somebody don't ever get filled. Not talking about do they take them, just don't even get filled. And now when somebody comes in, part of that intake is we can pull that information down through our EHR using a third party that contacts with pharmacies, you know, that has that input from pharmacies, and know what medications are you actually on. Not what you're taking, but which ones have you picked up.
And I hope it will be helpful in mining data. That is, going back and studying large groups of patients, studying the effectiveness of treatments, the effectiveness of diagnoses. As you know from reading, there are many conflicting studies about the same things, you know, whether mammography is useful and at what age women should start having mammograms. That's something, the PSA for prostate cancer. There's lots of controversy about some of these screening tests, and I think that with the electronic medical record, with the information being put into digital format and therefore easily retrievable, I think that will improve our understanding of what works and what doesn't work in medicine.
There were also frustrations with electronic medical records that the physicians expressed.
When electronic medical records came out, I had many patients complaining to me that their doctor would have their back turned to them, typing on a computer and asking them questions at the same time, and would never have the chance to even look the patient in the eye.
They print out the records and fax them or bring them to us, and you ought to see what printed out electronic records look like, at least in 2014 for most of the software. A visit for a cold that should be like 3 sentences long can generate 4 pages of paper that it takes several minutes to even find out what happened in the visit. A lot of the products are just not very user-friendly and didn't seem to be developed sitting down with somebody who's seeing patients. For example, in the old system, and again, I don't believe we should turn the clock back. In our old system here, when I finished seeing you as a patient, I had one sheet that I could check off the lab I wanted, when to come back, and it took me like 10 seconds to do that.
Okay.
Now, to say when you come back, what kind of bill you're going to get, what blood tests you're going to get, and so forth, it can take me 5 minutes and 50 clicks navigating back and forth. Not joking, I've counted them, to do that. So take 10 patients, the extra 5 minutes for each one, that's an hour of wasted time.
And of course, the other problem we have with electronic records is they do not talk to each other. So I'm now using Athena Health here. Palmetto Health is using Centricity. No, is using Cerner. Lexington is using another one. Providence is using Centricity, and a few smaller groups are using others, none of which can communicate with each other. Now, the VA hospital system does have one, where most VAs in the country can find out what happened. The military has a system where if a soldier gets malaria in Afghanistan and comes back home, they can see exactly what his initial treatment was.
The automatic nature of electronic health records allows the phenomenon of upcoding, the intentional or unintentional ability for physicians to bill for more or higher level services.
And all of a sudden I'm noting now that my cardiology colleagues are doing full neurological exams because you can click that normal button and it's done. It's very easy to do more than you say you do. For some reason, it's easier to do it with a computer than with a dictaphone. With a dictaphone, we never tended to dictate something that we didn't do, but with a computer, it's just so easy to click that all normal button.
Are you talking about upcoding, where you...
Yeah, kind of. I don't know that it's intentional. Maybe it is, but it is very easy to do that with a computer.
With advances in the electronic medical record technology, these frustrations should be addressed in due time. The future is bright for electronic medical records, especially with the younger generations of doctors.
Well, I've never used anything else. I guess I'm new enough to where that was had already come down the pipe by the time I'd gotten into clinical medicine.
Right.
And it's now a requirement. It's becoming required for hospitals to get government funding to have electronic medical systems.
Preventive care is a large part of the Affordable Care Act. New insurance policies now cover preventive services including screenings and counseling without the patient having to worry about copays, deductibles, or coinsurance. This is a move to make the population healthier and promote disease management. Preventive services include screenings like mammograms and colonoscopies and can help detect cancers earlier in a population.
As an enterprise, medicine has tended to be increasingly focused on disease management, and what we're trying to introduce now, and I think through the Affordable Care Act, because of the focus on prevention and preventive measure coverage, are really trying to get back to how do you keep a population well.
Again, I don't think this is a slam dunk 180-degree change from previous to the Affordable Care Act. I think, again, decent insurances did cover most accepted preventive services. Now, previously, sort of the bad insurances, or the ones that had extremely high co-payments and deductibles, sort of catastrophic, didn't cover that. And my understanding is almost all the plans, whether they're sort of Cadillac ones or sort of bare bones ones, will have to have preventive coverage. So that is a difference. Then the other question is cost savings, and I think, as you kind of hinted there, it's controversial, and it really depends on what the preventive intervention is. And also, to think about prevention as only a good thing if it saves money is actually probably an incorrect way to look at it. In other words, if a preventive intervention applied to a population costs more money than it would have if you didn't do that, but it saves lives and relieves human suffering, then it might be where dollars should be put, costly dollars should be put, as long as they're put there and not somewhere else, okay? So really, the question for preventive interventions, like any other interventions for sick people, is whether the incremental cost to do it is perceived as a valuable thing to do in the sense of prolonging life or increasing or improving quality of life. It's so interesting that after bunches of randomized trials, there's still controversy over mammography and PSA screening and a lot of these things. Actually, probably the one preventive, since you brought up cancer screening, we'll just go there. Probably the one preventive cancer screening intervention that is considered completely uncontroversial is Pap smear testing to prevent cervical cancer. Mm-hmm. That was never studied in a randomized trial, which is the benchmark now. It was introduced many decades ago and I think that the seminal study was I don't remember where this happened, where a certain geographic area began intensive Pap smear screening and an adjacent one with a similar population didn't. And then they looked at invasive cervical cancer, and there was such a dramatic difference over the next X years that it would have been felt unethical to then suddenly start randomizing people. Mm. And there's a lot of biological plausibility to why Pap smear screening and then intervening early on can improve outcomes. For PSA and mammography, you're sort of looking to find small, already existing tumors and then do surgery or do some kind of intervention. And the clinical trials are all over the map, to be honest, for those things. The age limits are uncertain because the clinical trials are the outcomes are not straightforward for many of the other cancer screening interventions. And then the false positive, we talked about cost effectiveness a few minutes ago. Right. By one analysis, PSA screening, if you take the most optimistic figure about lives saved by PSA screening, which is a tiny proportion of men who would undergo it, for each life saved or for each life extended for a certain number of years, it would cost millions of dollars, you know, in a cost effectiveness analysis. And the question is that worth it?
The Affordable Care Act now holds hospitals accountable for their performances, withholding payments if they do not meet certain measures. The purpose is to ensure hospitals are reducing their hospital readmissions and providing good quality care.
One of the pieces in the Affordable Care Act has to do with value-based purchasing. So we report our performance on certain prescribed things to CMS. And in return for that, we're either rewarded or penalized. So for example, in 2013, 1% of our Medicare payment was withheld, which we were then able to earn back based on how we performed against a number of measures. You know, did we provide heart failure patients with certain medications? Did we give them appropriate discharge instructions? And the same thing was true for patients with stroke, or excuse me, for heart attack and certain surgeries, those types of things. And fortunately, we did very well on that. We should be doing these things anyway, and all hospitals should be doing these things. The stakes got a lot higher though with the Affordable Care Act, because now not only should you be doing them, you are not going to receive full payment unless you're doing them.
Another ingenious way hospitals have been able to reduce their errors is through the checklist used before procedures. Spearheaded by surgeon and writer Atul Gawande and elaborated upon in his book, The Checklist Manifesto, the use of the checklist is now common practice in hospital operating rooms.
Dramatic. What a dramatic change. Even from just a year ago, that was something that by many physicians, many surgeons, the introduction of a checklist was not felt to be very helpful, right? These are the things that I do anyway. I don't operate on, I'm not a surgeon, I don't operate on the wrong leg or the wrong body part. I do identify the patient, I identify the complications ahead of time, I know them, right? I mean, that is our belief. But what Gawande has demonstrated, that research project that they have done and then expanded to other areas, is that there's a consistent reduction in complications and mortality. So if I was already doing that and my team was already working effectively, where does it come in? You know, where does the effect come in? Well, sometimes maybe I was doing things, but I wasn't sharing that my understanding with the people in the room. So one of the things that the checklist has done is it has given everybody in the room more information. It is also given permission to the other people in the room to speak up. So I, as part of my administrative role, I was rounding with a physician the other day, a surgeon. He invited me into the OR. It's really cool. So I got to see the checklist in action. And by the way, it wasn't the surgeon begrudgingly standing there holding the checklist while somebody read it off and he fidgeted. He started. It was a thing of beauty. He started when he walked in the room, and he said, "Hi," to everybody in there. He says, "I'm Dr." By the way, they all knew him, but he went through it. "I'm Dr. X," and he said, "We're going to be performing he listed the surgery on this patient today," and he named her by name. And the surgery happened, this particular patient, to be a mastectomy. She was having a mastectomy for breast cancer. So he said, has the breast been marked? And by the way, he had marked it. And so the staff acknowledged that. And he went through a few questions. He said, "Now, can everybody introduce themselves by their name and their role?" And they did. It was by their first name. "Hi, I'm Ann, and I'm the circulator today." He said, "Are there any things that you're concerned about?" And one of them knew that this particular physician didn't like to use paralytics on patients on a mastectomy, because when he gets down to a certain level of dissection, he wants to make sure that he can, when he touches the nerve, that the muscle will react, so he knows that he won't hurt the nerve. That's pretty cool. The nurse anesthetist knew, because she had worked with this doctor before, and she says, "I have one." She said, "This patient happens to have emphysema." And as we were getting her settled down, from a respiratory standpoint. She's on the ventilator. She was, they call it bucking the vent. She was coughing. She said, and so that I can make sure that she's not moving, even though she's completely anesthetized, she's not moving against the vent, I had to use paralytics. I know that that's not what you typically like, but this is what I'm prepared to do, is that as you get closer to that area and you're concerned, I will relieve the paralytic so you will not injure the nerve. I am blown away. Had no idea that that level of conversation was taking place anymore. By the way, that level of conversation didn't used to take place. If I'm the surgeon and I don't want somebody paralyzed, then I don't want them paralyzed. You deal with the bucking. And by the way, you better keep them still. So how you do that without that's not the conversation that was in there. And he invited everybody in there. If there's anything that happens in here that is concerning to you, I want you to tell me. If there's anything that I'm not attending to, I want you to let me know. And I'm going, oh my God. Yeah, this is real. And now it's just become an expectation. And I think that we've seen benefits just like Gawandi's research showed. We've seen fewer complicated, we've seen more efficient processes as a result of using this. Not, oh my God, I've got 3 minutes to go through this meaningless checklist, which was words that came out of people's mouths. But now that, and it wasn't 3 minutes, it's usually even shorter than that, but by anticipating things that will arise and being ready for them, it's made us far more efficient.
In medicine now, physicians are increasingly wanting to practice evidence-based medicine. This trend emphasizes looking into the research to determine how to prescribe good quality treatments with the best outcomes. However, it can be very difficult to decide what exactly is a good quality outcome.
There are certain things, say in cardiovascular medicine in particular, that we know if we do X, that there's a really well-proven statistical benefit over the next 10 years of reducing the risk of heart attacks or strokes or things like that. Right? So that's one kind of outcome. The problem is that everybody wants to do evidence-based medicine and practice in a way that improves outcomes, but where we don't have those, there's been a jumping the bandwagon to look at what's called surrogate outcomes. Are you familiar with that term?
No.
Big thing. Surrogate endpoints. So, because we know, for example, that HDL cholesterol, that's what they call good cholesterol, if you're born with it, the higher that one is, the better your outcomes are. No controversy over there, just in an observational way, right? So the question is, if we give a drug that raises HDL cholesterol, does that, that's the endpoint, is that necessarily good? Now I picked an example that's a really easy one, because the first drug that was in development that doubled HDL, anything, it was beyond anybody's imagination, by blocking this enzyme. When the clinical trial was done, the rate of heart attacks was higher in the group that was on the drug and had higher HDLs than the group that was in the placebo group. So that's an example of everybody being hyped about a surrogate endpoint, this number that you get out of testing your blood, but you don't care really what the number is, in a tube of blood. What you care about, are you going to avoid heart attacks or strokes or other bad things happening to you? So there's this whole literature now about, and then for diabetes it's the same thing. For years, people have used this blood test. It's called hemoglobin A1C that measures your integrated sugar levels over the past 3-6 months. Basically, some quality indicators have used that as the outcome. If you get the person's A1C down, you get brownie points and bonuses. And then the big randomized Accord trial was published a couple years ago, and these were people with long-standing, older patients with long-standing type 2 diabetes, and the group that had more intensive lowering of A1C had a higher mortality rate in a randomized controlled trial, the gold standard. So here's where I'm getting to your, using the evidence and so forth.
Right.
If you pick the wrong endpoints, particularly surrogate endpoints, you get into trouble. And because they're the easiest things to measure and they take less time to do a good, mortality outcome study, you have to wait years often. And so doing the studies are really expensive, right?
Yes.
Whereas you can just measure, in a couple months whether the drug lowered your sugar or lowered your cholesterol level or whatever. So there's this temptation out there to use surrogate endpoints and then to try to institutionalize them as the benchmark to say you did good, you did well. But in fact, it's not always so simple. Okay, so there's that. Then, the other things that complicate your question is there's been real attention to patient satisfaction. And think about rewarding physicians by doing surveys if their patients are satisfied. Now, there's been some studies showing that it doesn't always track other things that would seem to go with quality of care. So a group of satisfied patients might be satisfied with my bedside manner and how my office treats them and so forth, but if I practice sort of bad medicine, and they may not know that, is that a good thing? But I may get the highest ratings for satisfaction. So there are some studies showing that patient satisfaction does not always correlate with sort of independent, objective, high-quality care based on outcomes. So, so again, I mean, we could go on and on here, but it's a complicated, in general, yes, we'd like to reward people for practicing, high-quality, cost-effective medicine that use evidence and produce good outcomes. But in many cases, it's hard to measure the most meaningful outcome and decide on what is the most meaningful outcome. It's more complicated, unfortunately, than is at first glance, than it seems at first glance. I'll give you another good example. Another thing, there's this movement, or movement may not be the right word, but there's this entity now of clinical guidelines, clinical practice guidelines. That's actually a standard buzz phrase now. And another way to sort of rate somebody is to take a clinical practice guideline and then look at, the physicians in the practice, individual physicians, the group as a whole, and how well they adhere to the guidelines. And that's been used in some cases to measure quality. What's the problem there? The problem is who makes the guidelines. So the first set of big cholesterol guidelines produced by NIH, the people who were on the panel, almost all of them had done drug company sponsored research and had received fee, the conflict of interest issue. So there's this whole thing now about conflict of interest in guideline writing that may kind of subtly steer people towards doing things that the authors of the guideline may have a financial conflict of interest for. The other thing is everybody's in the guideline writing business. So if you want to look up, breast cancer screening, there's probably 6 different organizations that have guidelines. This one says screen everybody yearly starting at 40. This one says we don't know so much, maybe every other year after age 50. And so which guideline do you pick? So there's so many variables here that make even that a difficult benchmark to use to rate somebody's quality and whether they're doing evidence. If you can look at some guidelines, there's this movement to kind of standardize how they're written, in a way that's trustworthy is the term now, trustworthy guidelines, that is very upfront with what the consensus process is, what were the conflicts of interest in the people that wrote them, and then rating each guideline, whether it's based on randomized trials, expert opinion, observational studies, and making that extremely explicit, so that because of all the criticism of guidelines that I've just kind of alluded to. So, so any of these things can be used to rate quality, but all of them have problems.
Who should be in charge of writing guidelines, do you think, to make it the most neutral, but you don't want someone who's not an expert, on the other hand, in the area. So how can you eliminate conflict of interest entirely?
That's right, yeah. That's a great question. So here's the question. I don't have the answer, but here's the question. So you're going to write a cholesterol guideline. Is the expert in the area the person who spent their life doing research in it? Is it the person who may have got a lot of dollars from the cholesterol drug companies? Mm-hmm. Is it somebody who has done research, in cholesterol trials, but not gotten sort of funding from industry? Or is it from generalists who see patients with this but who have some training in statistics and epidemiology, who have no connection from a research perspective with the cholesterol drug companies or whatever, but who feel they can analyze data in an impartial way? So that's what these panels struggle with. And the question you asked has been put out there. Who do we put on these guideline writing panels? Exactly the way you expressed it. And it's a big controversy. What the U.S. Preventive Services Task Force does, which I think, to get back to your question, I think they're the most unbiased group. So it's it's a government appointed but independent, whatever that means, group of national people representing different fields of medicine, nursing, biostatistics and public health and epidemiology, brought together to look at each of the preventive medicine potential interventions and write guidelines. And then their guidelines are so evidence-based and objective, if you call it that a lot of them end up, the recommendation is, the evidence is too weak for us to make a recommendation. Which is good on the one hand because it alerts people that the evidence is weak. It frustrates clinicians to say, but the patient in front of me, I have to make a decision. Give me some better guidance than that. Now that task force, when it's going to do something, say on PSA, and they came out last year with a guideline against PSA screening. Oh. The first organization. They recommend it. They recommend four things. We're not sure because the evidence is weak, and against. So last year, the U.S. Preventive Services Task Force came out with a guideline that recommended that we should not do PSA screening. And I think their modus operandi is to invite the experts in panel discussions to give them input. But the final writing is not done with the urologic surgeons or the oncologists who treat prostate cancer. It's done by people who are trained in analyzing data, but don't have a vested interest either way. But they do, at least the way they describe their deliberations, they do invite input along the way from people who may have both practice and industry sort of conflicts of interest. Yeah, but then the final guideline writing, the specialists who may have interests in it are marginalized. They're not part of it. So I guess in academic general internal medicine, we tend to use their guidelines as opposed to the ones that are elaborated by professional societies or by advocacy organizations. So when I mean advocacy organization, I mean like the American Cancer Society. That's a public advocacy, fight cancer organization. They put out cancer guidelines, but they have their own. The American Heart Association is an advocacy organization. The American College of Cardiology is a professional organization that cardiologists belong to. You see the difference?
Yes.
And in recent years, the American Heart Association, the American College of Cardiology, all the guidelines, they now share the writing. So they're coming from sort of both organizations together. So you have to look at who the sponsor is and what vested interests they have.